All right, here we are. Still me, Ruth Lochte, looking forward to talking today and sharing a nice discussion about this important topic. I have no financial disclosures. Some of the work we'll be discussing today is funded by the NIH, and here are the grant numbers. Objectives this morning will be to briefly review the state of recurrent pregnancy loss, current recommendations for evaluation, and spend a little extra time on genetic testing, genetic causes and contributions, and introduce some of the research that we are doing and how you and or your patients can get involved if you're interested. So miscarriage matters. Miscarriage is extremely common. It's estimated that about 23 million miscarriages occur every year across the world, over 1 million in the United States every year. It's commonly quoted that it's about 15% of clinically recognized pregnancies, but with more sensitive pregnancy tests and closer monitoring, these numbers can be as high as 50%. Known risk factors. We all know that as our parents age, our patients, mothers and fathers age, the risk of miscarriages will increase. Additional risk factors for miscarriage include prior miscarriage. So as patients have increasing number of losses, their risks go up. There are racial differences. Smoking and environmental exposures have been linked to miscarriage, as well as the weight of the pregnant person and certain working conditions such as night shifts, just to name a few. Recurrent pregnancy loss affects 2 to 5% of families who are trying to achieve a birth. Recent data and interesting research has demonstrated there are numerous short-term and long-term effects on the pregnant person, including increased risk of cardiovascular disease, stroke, as well as other psychological diagnoses, both short and long-term, that seem to be either a consequence or potentially a cofactor in recurrent pregnancy loss. When we talk about miscarriage, we want to look at this in terms of a spectrum. What percentage of potential pregnancies make it to live birth? So many conceptions, that's a fertilized egg, may never implant in the uterus. Then there are embryos that may implant, but not reach the clinical diagnosis of pregnancy, which would be a visualization of a pregnancy on ultrasound or pathologic tissue diagnosis. About 10% of conceptions end in miscarriage or fetal demise, and only about 30% of fertilized eggs make it to the live birth that we see. So this myth and this story that we see in the media when we are, and I know we just passed April Fools, all these people who say, oh, my pregnancy test is positive, then in the movies, fast forward, then you're in the delivery room. So this, what happens between positive pregnancy tests and delivery is really poorly understood, poorly covered in the media. And there are a lot of myths about how easy it is to get pregnant and how a pregnancy test turns into a baby in a snap. So part of our job as clinicians is to normalize or to just help our patients understand that it's that conception to live birth is not a guarantee. Recurrent pregnancy loss. The definition of recurrent pregnancy loss has evolved over time. When I started my training, very strictly, we stuck to 3 or more losses that were consecutive before we would worry about recurrent pregnancy loss. More recently, over the last 5 to 10 years, the American Society for Reproductive Medicine, ACOG, the European Society for Reproductive Medicine as well, have all moved to a diagnosis of 2 or more losses. And the reason for this is really patient-driven. Patients don't want to wait till they have 3 losses to get attention or testing or a workup. So after 2 or more losses, most of our guidelines are now not only including the criteria for diagnosis of recurrent pregnancy loss, but in a shared decision model, allowing and even recommending a workup depending on other comorbidity factors. These are somewhat controversial still, and there's no one right or wrong answer. I think we have to individualize our care for our patients. The other area of somewhat controversy is these preclinical losses. How do we count those? Does a positive pregnancy test get counted in our G's and P's, right? The European guidelines currently do include them. American guidelines still are somewhat vague on that, but I'm working with the American Society for Reproductive Medicine to kind of level up that our guidelines are the same worldwide. Additionally, the guidelines disagree whether these losses have to be consecutive or not. Again, this is where you have to look at the whole picture. How worried are you about this patient? And in your judgment, is it best to work them up if they have non-consecutive losses based on other factors? Additionally, all guidelines have distinguished recurrent pregnancy loss from infertility as a separate diagnosis. Although, as I was mentioning before, that they do have some overlap in terms of the challenges in getting insurance coverage and getting support from family and providers. The most recent ASRM guidelines, which I'm sure most of you are aware of, came out from ASRM in 2012 about how we should be evaluating these patients. The three things that are really unique to recurrent pregnancy loss are antiphospholipid antibody testing, a uterine cavity evaluation, and chromosome testing of the parents, meaning a karyotype. TSH, prolactin, hemoglobin A1C are recommended if there are risk factors present, as well as preconception care optimization and supportive counseling. These are really important part of what we do in recurrent pregnancy loss and shouldn't be dismissed as, kind of afterthoughts. This is really the core and the center of what we do when we're taking care of patients after a miscarriage or in between pregnancies. It's rare that we really have this opportunity to examine the health of the pregnant person before the next pregnancy and ensure that the health is optimized. Embryonic chromosome testing is still somewhat controversial, although I'll give some rationale for why it's becoming more commonly done. But the ASRM guidelines currently do mention that karyotype can be done in the setting of a treatment failure to explain, say, why did the treatment for antiphospholipid syndrome, for example, not lead to a live birth, or, oh, I treated her thyroid disease and she still miscarried. I wonder why. Well, often it can be explained by the fetal chromosomes. As I often teach about this topic and work with trainees and students and residents and things like that, I really like to distinguish what are specific causes of recurrent pregnancy loss versus sort of these risk factors for miscarriage. In the Lancet series that I mentioned earlier about Miscarriage Matters, they actually support this idea that every patient who experiences a miscarriage deserves an evaluation of some sort. So patients who have had a miscarriage, this is a really impactful life event for most of our patients. That even if it's when we say just one, I don't like to use the word just when I'm talking about miscarriage, but even a single loss deserves some consideration of all of the risk factors. So when I am talking with patients and trainees about this, even after a single loss, you should consider these risk factors. Does the patient have a strong family history of thyroid disease, irregular periods? Is her weight high, or does she have risk factors for diabetes? Check these things. And then generally preconception care optimization every patient deserves this before even their first pregnancy. We often don't see them, but when they have a miscarriage, this is an opportunity to empower your patients that there are things they can do before they get pregnant to help set themselves up for a healthy pregnancy. These include things like nutrition, prenatal vitamins, avoiding toxic exposures to tobacco, marijuana, alcohol, other exposures in their lives that they can reduce. That can be done before pregnancy to set up for the best chances of health. And then supportive counseling. A single miscarriage to us, the healthcare providers, we can get a little desensitized about this, that our patients, that we see, oh, miscarriage is common. I've seen so many people have a miscarriage and go on to have a live birth. It's nothing to worry about. And we say these things with a very well-meaning intention, meaning we're not dismissing the miscarriage, we're just trying to encourage them. But patients need to process. This is something for some of our patients, the first time they've ever had any health problem or anything in their health go wrong, and really need time to honor and grieve the loss. So give them that time. Check in with them. This is critical to maintaining the doctor-patient relationship, and it will help with adherence to other recommendations that we make. So make sure you give the patients the support they need during a loss, as well as kind of just set up that therapeutic relationship with them. Additionally, many patients will need referral to mental health supports. So if you're seeing that patients are having difficulty coping, unable to sleep, unable to go back to work, this kind of thing, think about those referrals. We have great mental health providers in the community that really are dedicated to caring for our patients after a loss. So what we have for specifically for recurrent pregnancy loss that is unique, that just to recurrent pregnancy loss, is these 3 tests: the antiphospholipid antibody testing, uterine cavity eval, and parental karyotype. So I always kind of say, in medicine, if you can remember 3 things, you've probably got 90% of your answer right by now. So remember these 3 things: phospholipid testing, uterine cavity eval, and parental karyotypes. Unfortunately, we can do all of the things that ASRM recommends for us and still have a very high percentage of patients that are unexplained. So what do we do then? And I'm sure every single person on this call has had a patient like this, where she did all the testing and everything was normal and you had no answers for her. This can increase our patients' anxiety and, in some studies, depression, that when we don't have an explanation, whether it's because of societal messaging or patients' guilt about something, that our patients can end up self-blaming and really becoming depressed over the loss and not understanding what's going on. So seeking answers and supportive care is critical. Why are so many pregnancy losses unexplained by our society guidelines? What is the cause of these 50 to 70% of patients who've had losses but no clear explanation? Well, I would argue, and we're going to spend the next 10-15 minutes talking about this, that are we looking in the right places? When we see a person who's suffering with recurrent pregnancy loss, we examine that person, right? Is there something about that uterus, the systemic environment, that are causing miscarriage? But what the reality is, the disease is in the miscarriage. That pregnancy did not develop normally. So maybe we should be looking there. What is the cause of the loss? Is it a maternal or a host problem, or is it actually the embryo or the fetus? And I will argue that the majority are in the fetal genetics. So here's some data about that. So the number 1 cause of miscarriage is chromosome problems in the miscarriage. Here's a classic study that says, here's the maternal or the pregnant person age. As that age goes up, the percentage of the miscarriages that are chromosomally abnormal also goes up. So at age 40, it's almost 80% of the losses will be chromosomally abnormal. But even at a very young age, it's about half. So when I always go back to when we don't have an explanation, often it's because we didn't check in the right place. Chromosome problems of the pregnancy are the number one cause of pregnancy loss. And that is a reassurance to our patients that they didn't do anything wrong, that no matter that whatever they did, what if they ate a unpasteurized cheese, or if they went on a long hike or something, that did not cause a miscarriage. The reality is most miscarriages are due to fetal or embryonic issues, nothing that the mother did to cause it. Now, as I mentioned, chromosome problems are the number one cause. They give us an answer a lot of the times. But what is recurrent pregnancy loss? What is at the core that we are trying to solve here in recurrent pregnancy loss? Is it chromosome abnormalities, or is it these euploid pregnancy losses? And this is a very classic study, and there are numerous others, but I just like this graph of as the number of pregnancy losses goes up, we see an increasing incidence of euploid or chromosomally normal losses. So if you look at this graph, the average age of this cohort, I think, was like 33 or 34, that a high percentage of losses, when the number of losses is lower, like 2 or 3, the majority of those are still going to be chromosomally abnormal. But as you get to 4, 5, 6, and more, there's a higher chance that the chromosomes are going to be normal. So I showed some data that as a maternal age increases, chromosome abnormalities in the losses increases. However, the converse is true. As the number of losses increases, the chance that the miscarriage is chromosomally abnormal decreases. So age, number of losses, those are kind of data points that I use when I'm counseling patients about what is the likelihood that your losses were in the past and are in the future likely to be due to chromosome problems. So when I see a patient with pregnancy loss, whether it's her first or her 5th or 6th, what's the number one question we get? You all know this, right? The number one question is, what caused my miscarriage? And then the second is usually some version of, will it happen again, or what can we do to prevent it from happening again? So number one, people really are seeking answers to what caused their pregnancy loss as much as they're seeking answers as to what to do about it next, because of this psychological impact of not having answers and having a really hard time moving forward without answers. So chromosome testing, so in order to find answers for our patients, we really do need to do this chromosome testing of the miscarriage. If we look at the chance that your workup is negative, that means you do all the tests and you find nothing. As I mentioned in a prior slide, your standard workup, just looking at parental factors, chromosomes, phospholipid, and uterus, you're going to come up blank or negative about 50 to 70% of the time. If you add the chromosomes on the miscarriage itself to these other 3 tests, the incidence of unexplained recurrent pregnancy loss drops dramatically to 10 to 25%, depending on which studies you're looking at and what cohorts you're examining. Additionally, multiple studies have demonstrated that finding an answer for your patient not only reduces the incidence of unexplained and increases patient satisfaction, it reduces costs to the system. When people don't have answers, they want more testing, right? So we end up chasing and doing a lot more testing if we don't have an explanation. What new guidelines will come out is that once you have your explanation as the chromosomes, you can stop your evaluation there. So you can save a lot of time and energy and money that way. Patients are more satisfied when they have answers. I don't have to tell you that, you know that. And there are newer and more available options for patients to do testing at home of their miscarriage. So I really encourage people to explore that if a patient is wanting answers but doesn't want to do a procedure. And I'll share with you some new guidelines that are coming out, 2024, 2025 guidelines that really welcome changes to these guidelines that we are going to be seeing more and more guidelines to support the testing of these patients, and hopefully insurance coverage will follow. So as I alluded to, ACOG put out a clinical expert series. It's a little bit hard to find, so I want you to just kind of, I don't know, screenshot this or something so you can go look at the whole thing. It's the whole guideline that came out. This is an ACOG expert opinion on evaluation and treatment of recurrent pregnancy loss. It's very, very good, and it incorporates miscarriage testing. And I was very, very happy to see this and hoping that ASRM will follow. So in this expert series, the first test they recommend is miscarriage chromosomes by chromosome microarray. And I don't have time to go into it today, but there are a number of different methodologies for testing miscarriage tissue. And the microarray is going to be your most highly recommended test, mostly because it will decrease culture failure, and it allows you to differentiate maternal from fetal cells. So as you're incorporating this into your practice, look at the which tests you're ordering for accuracy. In cases of unexplained, they're recommending the same kind of 3 tests that we did, which is the parental chromosomes, phospholipid testing, and uterine cavity evaluation. Thyroid testing is really, we can do a whole lecture on this. Kind of comes and goes in terms of the recommendation. ACOG is recommending thyroid testing for all patients with recurrent pregnancy loss, whereas other guidelines are more focused on risk factors. But again, we keep hearing this lifestyle modification and supportive care. These tests are helpful, but this intervention, I think, is the most impactful. And every person on this phone call can provide supportive care to our patients and give advice about best lifestyle for setting up for success in pregnancy. We think our patients know all these things, but every time I go through these, there's going to be something there that patients may or may not have known about their lifestyle and what they can do to make a pregnancy more successful. So share your knowledge about prenatal vitamins, folic acid, avoiding toxic exposures, this kind of thing. There's always something we can do to help support our patients. So as I mentioned there, the ACOG guidelines start with miscarriage chromosome testing. As I'm working with the American Society of Reproductive Medicine on our guidelines, we are also incorporating the chromosome testing here, and it sort of looks like this, and it's a little bit busy, so I'll take a second to let you guys take a look at this. So first test, if you have a patient who's presenting with their second or more loss, offer chromosome testing. If you find that the loss is aneuploid, you honestly need no further workup. A septum in the uterus or phospholipid syndrome doesn't cause aneuploid loss, so you don't test for that. So we usually stick to our psychological support, reassurance, preconception counseling, health optimization for both partners. And I always like to, because I'm a fertility specialist, like to evaluate for fertility conditions if they exist. Does this person have infertility as well as pregnancy loss, or is she getting pregnant easily? So sometimes a fertility evaluation will be needed if there's delay in conception. The other really high yield aspect of your chromosome testing, let's say you diagnose a translocation in your miscarriage. Well, then that's a really good time to check the parents and see if they have it. So if it's aneuploid, we know that's not from a parental chromosome problem. If it's unbalanced, we're going to recommend that you check the parents. In the setting of a euploid pregnancy loss, then we do the full thing. We do the uterine eval, the TSH, the phospholipid, and then any additional testing that might be indicated based on history. Unfortunately, if there's no miscarriage testing, you kind of get the whole thing, right? We don't know if a parental karyotype is needed, so we have to add that. And then We also test the uterus phospholipids. So you can see how doing the testing can limit the amount of follow-up tests you may need. The most expensive and the most time-consuming approach is if you didn't test the miscarriage, you have no idea what kind of miscarriage it was, you got to do everything. Regardless of the number of losses or the findings of your evaluation, this here at the bottom is the number one job we have as providers. We really want to support our patients, reassure them that regardless of what we find on this test, there is a good chance of success moving forward. And their job as people trying to conceive is to focus on healthy habits and preparing their bodies for their next pregnancy. Psychological support and reassurance. Like I said, it's not an afterthought. It's a core of what we do. Anxiety and stress are associated with worse outcomes. We know that these conditions can lead to delayed pregnancy, and the association, we don't know if it's cause or effect, but so common that people have anxiety during this process. So we want to address that. Time with providers and care team is magic. So patients feeling heard, patients feeling safe in their healthcare environment, that alone can reduce anxiety for patients. Refer to your mental health providers when indicated, and very liberally. I think that our patients tend to show us their strongest side, and maybe not even let you know how much they're struggling. So offer mental health referrals very liberally. I do for every single one of my patients. They don't have to take it, but when you offer it, you sometimes are surprised who's going to take you up on it. In California, I'm assuming most of us here are in California, a new law was passed that protects people for grievance after a pregnancy loss. So it's a legally protected right that patients have 5 days off work without penalization in California. Recommend that patients take this time. I've had patients who, physically, push themselves through work the next day. We all see, healthcare providers and other really hardworking people in our practices who just want to pretend like it didn't happen, have a miscarriage, go back to work the next day. When I recommend this time off, I have seen patients recover much faster in terms of emotional and physical health. So give people that time that they need after a loss. Ask them to focus on their own health. Reach out to their support groups, and then any mental health providers that they need during that time. Evidence-based counseling, and I kind of call this counseling with confidence, that recurrent pregnancy loss is not a mysterious disease that we don't know what to do and we don't know what's going to happen next. It's common. We have tons of data, and I'm going to show it to you in a second. Good pre and post conception evaluation and counseling. Kind of this message that I've got you. I'm here with you. We're going to solve this together, and we're going to be in this together till the end, kind of thing. When I say counseling with confidence, there are numerous, as I mentioned, case series of patients with unexplained recurrent pregnancy loss. Those patients who we do our workup, we don't find an explanation. What's going to happen with their next pregnancy? We don't have any specific therapy for these patients. We say we've optimized your health, we've got you on your prenatals, and we don't have any specific therapy for you. Let's see what happens with your next pregnancy. The odds of a successful pregnancy in the very next attempt without any unproven therapies. So this is not with people, going through blood thinners or immune therapies. This is truly trying again the natural way. The prognosis for live birth, not unexpectedly, is related to the age of the egg. The egg age is the number one thing that will predict aneuploidy, and so that is the number one thing that will predict future miscarriage. as well as you see a slight impact of the number of losses. So let's take a 35-year-old, for example. If she's had 2 prior losses, her workup is negative, she tries again, her likelihood of having a live birth is 75%. It's a little bit higher, but let's just say 75%. If she does nothing, we don't have a cause, that means it's very likely random or sporadic causes. Optimize health, get you on your prenatals, try again, almost an 80% chance of live birth with no intervention. This is one of the most beautiful things about recurrent pregnancy loss, but almost also our Achilles heel, because we don't have any treatments to make that any better. 80 is pretty good. 75 to 80% chance is really hard to beat with any treatment, even IVF. Take that same 35-year-old, and now she's had 5 losses. She's still at about a 60% live birth rate with no proven intervention. So a lot of us, when we see that person with 5 losses, are like, this person is never going to have a baby. We think that in our head. I hope we don't after this lecture. But she needs some kind of therapy to help her have a baby. Well, 2 out of 3 of them will have a successful birth with nothing. So all these anecdotes that we see, oh, I sent her to special doctor X or Y, and they gave her, special treatment X or Y, and then she had a baby. Well, it's really hard without comparative studies to placebo to know if that would have happened regardless of the treatment. So we can counsel with confidence that there's a high chance that most of our patients will go on to have a live birth, provided we rule out these treatable causes. Time with providers. Just want to do a quick time check. We have a few minutes still. Patient experience. So we talk about, in medicine, we can't always control the outcome of our patients' diseases, but we certainly can control how they feel. And so how do we improve the patient experience? Well, one study I did with some residents and genetic counselors was, do patients really benefit from doing chromosome testing in their miscarriages? And in fact, the satisfaction was very high and the regret was very low for people doing chromosome testing. But the other thing besides chromosome testing that really predicted whether a patient was satisfied with her care was, not surprisingly, amount of time with their providers. And we think, oh, these patients might, there's no amount of time that will satisfy our patients. The reason I put this data here is to let you know that it's not an infinite amount of time that these patients need to feel supported. That once we got to about 10 to 20 minutes with patients, satisfaction was pretty high. So this is a major life event for our patients. And all they need is 10 to 20 minutes of our time to sit with them, to go over the causes, and to help them understand their losses. So hopefully most of us here will have that time for our patients, and just know that it is extremely appreciated by our patients. If you'd like, go ahead and look this paper up. There's a lot about how patient satisfaction, her interaction with her healthcare team, and whether or not she found an explanation to her loss, not only improved her emotional recovery. So as I mentioned earlier, that without an explanation, people are really taking a lot longer to process their losses, but also her physical recovery. She felt back to normal faster if we gave her an explanation. So there is that link between emotional and physical recovery. And we go into that a little more detail in this paper. If you're interested, here's the reference. So next thing, I hope I have convinced you that testing the miscarriages for chromosomes is a really critical part of miscarriage care. Every good thing has a downside. So as we bring this up to our patients and referring providers, this is really important. What we hear back is that, I like it when it comes back positive because I know what to say, but when it comes back normal, then the patients get even more upset, or I'm more upset because I don't give her an answer. So what I like to go back, if I can take 1 or 2 minutes to just give you some talking points on this. Does euploid equal normal? And when I talk to patients and when you talk to your patients, I hope after this, euploid does not mean normal. Don't tell this patient it was a normal embryo, because normal is like, oh, we checked everything. There was nothing wrong with the embryo. We don't know that. All we know is it have 46 chromosomes. So I really go back to this. Euploid does not equal normal. Having 46 chromosomes does not rule out a genetic cause. And we know this from every other field of medicine besides miscarriage, right? Most genetic diseases are not whole chromosomes. They're little pieces of chromosomes or a single gene defect or a small deletion or duplication that's not picked up on a kind of high level microarray. So euploid does not equal normal. It just, I like to use it as non-diagnostic. We didn't find it with this test, but we still don't know if it was a fetal abnormality or not. Just raising that doubt to patients, because they are going to immediately go to, I lost a normal embryo or a normal baby. And that's not really true. And it's our job to take a minute to discuss that there's huge, huge limitations to chromosome studies when we're looking for genetic causes. Lots and lots of data to support this, that embryoscopy studies show there's a high rate of fetal and embryonic defects in miscarriages, even when the chromosomes are normal. We don't do embryoscopy studies. That's beyond the standard of care. But when people really look at these embryos and these fetuses, there are abnormalities. They're just not picked up by chromosomes. Our patients with recurrent pregnancy loss may be at increased risk for non-cytogenetic, non-chromosomal genetic abnormalities, meaning that these families have higher rates of severe birth defects than non-pregnancy loss patients. Some fetal anomalies will lead to miscarriage, and others might lead to a birth with anomalies. So seeing a higher baseline risk of anomalies in the births of patients with recurrent pregnancy loss is just the tip of the iceberg. Probably there are more fetal anomalies in earlier losses too. Why is that? Well, we're doing some research on that. Now, because I'm kind of genetic focused in my research, I get accused sometimes of ignoring all the other causes. Of course, I don't think 100% of miscarriages are genetic. I just think most of them are. And we do need to, and I put this in red because it's a shift in focus. There are very likely non-genetic factors that also cause miscarriage, but we need more research for these patients to understand what other causes they might be. Currently, there are few, if any, treatments to address these non-genetic causes of miscarriage, and therefore it's an area of active research, and we need to keep an eye on when these research studies are coming out. There are a number that are ongoing that are promising, but in the world of recurrent pregnancy loss, I can give you a whole lecture on randomized controlled trials that show that therapies that we thought were going to be effective failed to show benefit in randomized trials. So in our last couple of minutes here, I want to talk a little bit about the research that we're doing and leave some time for questions, that if you have questions about our research. So our recurrent pregnancy loss study that we're doing at Stanford with in collaboration with UCSF, Oregon Health Sciences, University of Pittsburgh, and gosh, I just rattled those off, and I'm sure I forgot somebody. University of Illinois, Chicago, multi-site NIH-sponsored study. We really are hoping to shed some light and gain some insight on what causes those unexplained pregnancy losses, those euploid pregnancy losses. What's going on there? We have a multi-specialty, really a pretty agnostic approach to studying this. We, of course, are first starting with genomics by sequencing patients and pregnancies affected by recurrent pregnancy loss. But we're also looking into metabolic changes, lipid changes, as well as immune signals, both pre and in early pregnancy, to try to understand the mechanism, what is causing these recurrent euploid losses. With this idea that pregnancy requires so many things to interact and happen at the right sequence and the right interactions for everything to work together appropriately and get that live birth from that pregnancy. It may not be genetics alone. It may be a combination of genetics and environment. It may be a combination of 2 or 3 of these factors. So once we collect all these data, then we have our computer science team really trying to integrate this, all these data to find a cause for recurrent pregnancy loss. Going back to the genomics, because that is sort of the first step of our multi-omics. I mentioned earlier, I hope I've convinced you, euploid does not equal normal. But what's going on there? What are the genetic causes of euploid loss? So step 1 of our grant, we are sequencing pregnancy losses and their parents for known lethal genes, as well as novel genes that might be associated with pregnancy loss. And we have our approaches and our algorithms to try to increase our confidence that the findings that we have are truly pathogenic. So we're going through a number of different approaches. And with this, we've sequenced about 150 families, and we have found explanations in about 20 to 30% of them. So we are actually, as part of this study, able to identify pathogenic causes of pregnancy loss, and even as part of our research, validate these studies, these findings, and return results to patients. So we've started this process, and we've already returned several results to families that can be acted on. So if you have patients who fall into this category, you can refer them to our study. So the study is called the HOPE studies. If you have unexplained recurrent pregnancy loss patients, particularly those with euploid pregnancy losses, we're really interested in helping you and them find their answers. So you can refer them to our study, and we'll take it from there. Anyone interested in a flyer or other information, I can send them to your office. There's nothing you have to do, just refer them to our website. Patients can sign up online. Ideally, we would want these euploid losses, so make sure you send the miscarriages for chromosome testing. There are some labs that are pretty good at holding on to that DNA, so we can get it back. So Dentera is one of those. Some of the hospital labs, the Stanford lab, will hold on to it as well. So if you consent them at the time of miscarriage, or we can enroll them at the time of miscarriage, we can get that fresh tissue and then later sequence it if it turns out to be normal. And then just spread the word to your colleagues, your residents, nurses, on about the research, and help us solve this really complex problem. I think we're getting close to time, so I don't want to spend too much time, but this is sort of the design of our study. Right now, we have about 2,000 individuals in our registry contributing data and samples. Our goal is to sequence about 500 families and then do these additional studies and more. Probably not needed here. The registry, you don't have to have any miscarriage tissue if patients want to be in the research registry. That allows them to be kind of on this list of, if further studies come up, we can contact them. They can also contribute data and samples depending on their history. And then the sequencing, there are some incentives for patients to provide samples for sequencing just because of the extra hassle. Our website is pretty user-friendly. It's called pregnancylosanswers.org. Patients can go to our website. There's a number of different banners and things like that, but basically learn how to get involved. There's also on a different page, enroll here, and then there's a description of our study. So if we can just get that information out to our patients, they can read about it. Let me know if you're interested. We have English and Spanish language support for the study and flyers in both languages. And here is how to contact us. So thank you very, very much for your time. This is a QR code for our study. This is our email. We would love, love, love to hear from you. And thank you so much for the opportunity to join you this morning. I'll take any questions.
Thank you, Ruth. Hi. I mean, you're back because it's such an interesting uncovered topic, and you're a wonderful speaker. So thank you for joining us again. We're really happy to have you. I got to just start off because I saw that and went, what? Night shift? Why is night shift a risk?
Why? I don't know, but I like to mention it because we have a lot of healthcare providers either on this call or, we all, I heard that a high percentage are nurses. It's been shown in multiple studies. I think probably sleep disruption leads to maybe some stress response or hormonal changes that that may be harmful for pregnancy. I don't know. We don't know. We're still investigating, but I definitely ask my patients to really look at their sleep patterns and make sure they're getting good sleep. You need to have circadian rhythms and things like that for a healthy hormonal balance. So perhaps it's that. Maybe it's other, maybe it's just sleep deprivation in general. That's a little harder to understand. But yeah,
very interesting. What about potential research, what's going on with the vaginal reproductive tracts and the microbiome?
Good question. I think there are a number of studies going on around this. And I think that there's a subset of our patients might be affected by this. Microbiome is such a complicated area of research right now. I've seen some anecdotes of treatments that are working for this. It's going to be hard to prove at this point. We do check our patients. So, what we're presenting here in a CME event is the national proven guidelines. But, in my personal practice, I kind of have like a first tier of tests, and those are the ones that we talked about. Everybody with 3 or more losses or 2 or more euploid losses should get the standard test that we talked about here. But a lot of people will ask me, what's your next level? What if that doesn't work and they still have a miscarriage? What's level 2, right? And in my next level of testing, I do check for endometritis, or that's an inflammation or a dysbiosis of the endometrium through an endometrial biopsy, and I do treat with antibiotics for that. We've had successes. We've published a couple papers on that, sort of a whole nother separate lecture of kind of secondary causes of recurrent pregnancy loss. We have a lot to learn in that area, but it is something that in selected cases we'll investigate in our practice.
I don't expect you to have all the answers to this next question, but I think it's all right. I think it should be asked. Insurance coverage.
Okay.
Especially for testing of fetal tissue. Do you have any kind of what is the more average cover? I know insurances
like
are
Medi-Cal, you mean, or other insurances?
No, I mean, even in other words, what standards do or what do you have to prove in order for an insurance company to cover further testing or testing of the tissue of the fetus?
Yeah. I think this is where we pull our genetic counselors in, especially for later losses, because there's always a debate on what's the best test, depending on if there's any ultrasound findings and things like that. We've had really good luck at Stanford getting miscarriage testing covered. Also, Valley Children's. I don't know if anyone from Valley Children's is here. They've also had good experience getting their miscarriage testing covered when it's recurrent. So 2 or more losses, they've had good coverage and really provided a lot of support for us. We learned from them at Stanford how to get this covered. So we've had good luck getting it covered. Some of the private companies, so for people with private insurance, it does vary a little bit. Worth checking into it. We send ours to a reference lab outside of Stanford that kind of has a cash pay price if insurance doesn't cover it, which is about $350. It's steep, but for a lot of our patients, it is within reach, and finding those answers is important. So looking into the different options is worth exploring. I've really rarely had trouble getting it covered in my patients, and I've noticed the same thing from our PDC. It's a kind of an old thing that we thought wasn't covered, but if you check, often it is.
You mentioned in one of the last slides about, your efforts, the study's efforts to reach communities who in the past haven't been reached out to as much. Thank you. Talk to us about racial ethnic differences, the populations. You mentioned stress before, you mentioned, sleep disturbance. Talk to us about that and what you see in the field.
Yeah, well, Dr. Tice, who's kind of in the middle of this, I don't know, is my pointer working? Anyway, on the left side here, we actually have tried to study genetic causes in underrepresented populations, and it's extremely challenging for a number of reasons. There are systemic reasons, there are cultural reasons that have led to lower inclusion in our studies. So we really need to make concerted efforts to increase awareness, engage communities. We've actually received now a second grant to kind of study this phenomena of race, the interaction of race and reproductive and genetic research. Why is it that we have such lower representation? We've had all of our study documents translated into Spanish since the very beginning, but still had despite being in California, very low uptake in the Spanish community. So we're exploring that. It's difficult. We do know that the biggest racial difference in miscarriage is between patients identified Black versus non-Black patients. We don't know why. We're investigating that separately as well. It seems that they're not receiving the same workup. So there may be a systemic difference, that they don't have access to providers who do the testing, or I don't know. We're trying to understand that difference, but it does seem persistent throughout the literature that there are differences in miscarriage rates between Blacks and whites, as well as the incidence of recurrent pregnancy loss is about double.
Thank you for mentioning that, and for also identifying structural reasons, and the need to look into this more.
Yeah.
First of all, I want to apologize. I'm Italian, so sometimes if I use my hands or this or that, then the thumbs up will come up, so it doesn't pick up on us folks.
Well, I thought you
use our hands a lot. What about I think I'm going through all my questions here. Sorry. And this will get us close, I think, by the time you end this one. Before your talk with us last October, I've been a nurse over 30 years. I've experienced a loss, a miscarriage. It was very early. Until we had members of the community and our professionals who joined us, Carla Avalos and others, Roots community, the speakers that joined us. Anyway, the fact that we don't view miscarriage as a birth, that the person has gone through a birth. Can you speak to that?
Yeah, well, maybe. I think that everyone's experience is different. A miscarriage, as I mentioned, can be very traumatic to a patient. A pregnancy is, for many women, a baby until, even before the baby is born. So the experience of having a miscarriage can be physically painful, emotionally painful, and many, many women will describe it as a birth. So we have to just be, I I don't know, sensitive isn't the right word, but supportive of our patients, how they describe their experience that is the definition of their experience. If it was a birth for them, and a lot of our patients do describe it that way, then we should use those terms as well. It is a significant life event, and for women who have been through it and haven't gotten that respect or that acknowledgement of how significant it is really kind of an unanswered, I don't know, wish or unanswered need until we really acknowledge it. And it can be very therapeutic to give it the meaning that it has to the patient. So
thank you, Ruth.
Yeah.
Thank you for that. And our last question will be, thank you for identifying your study and the resources at Stanford and big places like UCSF. What other resources are out there for birthing people who have experienced losses? What reading websites do you recommend? I'm definitely going to go ahead and include Erica, our speaker, who joined us in October. Everybody, I'll put that in a notification so you can see her advocacy effort. She's out of Beck East, wonderful speaker.
Yeah.
What else?
Yeah, there are a number of resources available. We actually, because this is such a common request, you can't really see it here, but on our website, under information for participants, there is a list of resources that patients can go to. I don't know, can you see how it says like hope, our little signal, and then about, and then if you, on the website under participants, there's a list of resources there. But there's so many more as well that patients can tap into. National support groups, lists of providers. Resolve is a patient advocacy group that has a number of resources available to patients with infertility, patients with repeat miscarriage, and they actually have a list of kind of like local support groups there as well. And you can get to that through our website. So
could you do me a favor, Ruth, after any time today, but if you could do it before maybe 2:00, if possible, can you send me the page I should be looking at on your website or where those resources are listed? And then I'll put it as a notification later today for everybody.
Yeah, so the website is pregnancyLossAnswers.org. But
okay.
Okay. Yeah, so we tried to make it easy to remember. And yeah, our other speakers also had some really wonderful resources as well. Reach out to your local social workers, psychologists, psychiatrists. The Women's Wellness Center at Stanford has a number of dedicated psychiatrists who work with women and fertility and pregnancy loss concerns. But not everybody is looking for a like a psychiatrist and medications. For support groups, I definitely would lean more towards the social worker and the psychologist option. But these are all things that we offer to our patients. If people are experiencing PTSD or severe anxiety, insomnia, we'll send them to the physician providers as well through psychiatry and women's wellness.
Okay. I didn't let you know beforehand, we have folks from 17 states on the call.
Okay.
The majority are, that's all right. The majority are from California, but we definitely have representation from across the United States, which we're very grateful for.
Yeah, that's wonderful. So then I would, the national website would be resolve.org, I think it is. And you can kind of navigate that.
Perfect.
Do that for, there's a number of others as well, which you can see on our website, which is now, our website is national. So there are some other national references there.
Ruth, we're very grateful. Thank you for partnering with us again, everybody. Thank you for joining us, and we're going to send you off to the next talk. Have a wonderful day.
Wonderful. Thank you.
Bye, Ruth.